places we have the, like presidents have their presentation, mayors and governors have their presentation, and we have ours as well. And Dr. Eisen is kind enough to come in and present the year in review as to what's happening in the technologies of heart transplant, the processes and so forth, and he's very happy to do so. The tough thing is taking notes because I'm listening as well. And with no further ado.
Okay, before I get started,
one of the other things I wanted to say is that our good friend Jim is here. He's going to be taping you because we always love him to tape.
All right, so be on YouTube then.
And you're on YouTube or whatever. And by the way, if anyone has questions at the appropriate time, please raise your hand so Jim can actually get the camera on you first, get your question, and then give him time to get the camera back on the doctor for an answer. Jim, is that okay?
And let me say, this does not go out on YouTube. Okay? This is part of a transplant presentation library where a DVD is made of this program. It's distributed across the country to TRIO chapters and to members at large, any place in the country that wants it. So it's a captive audience in that sense, but this is program number 36 in those 3 years of program. So, Dr. Eisen, I think this is your 4th appearance.
Wow.
And annual update on this. So.
I like the Justin Timberlake comment. not as funny. So you guys are introduced.
Yes.
And genies. Make a good impression.
We welcome him.
All right. Well, thank you for having me. It's always fun to kind of update you and let me tell you where things stand. And I always find out some additional information. Probably not that much this year, but at the International Society of Heart and Lung Transplant, which is in Prague this year, in about a month. So I'll be thinking about you guys. So let me talk. I'll start with AlloMap, or what we call gene expression profiling or molecular diagnostic testing. I think last time I spoke, I discussed the fact that there had been a big clinical trial that showed that at least beyond 1 year, maybe beyond 6 months, certainly beyond 1 year, stable heart transplant patients doing the AlloMap blood test was identical to doing biopsies in terms of patient outcomes. And so as a result of that study, an increasing number of transplant programs around the country have adopted the AlloMap for clinical purposes. And we were among the pioneers. We started doing that 7 years ago this month. And which is one reason why we weren't in the clinical trial. I don't know if many places in Philly are using it, but around the country there are about 80 places that are using it routinely, which is the majority of places. Will there be other tests developed that might supplement or take the place of the AlloMap? Perhaps. There's nothing at this point on the horizon, but I think that there probably will be at some point in the next few years. The other thing that's being discussed is the idea of a clinical trial similar to the one that was done, but that one was done patients 6 months or 1 year beyond transplant. If you think about it, rejection occurs within the first 6 months, and so this trial would start from month 2 and go beyond there to see whether using the blood test is similar to the biopsy in terms of outcomes. And that would be a more complicated study, but I think there's a lot of interest in doing that, and perhaps having the National Institutes of Health at least partially fund that. So there's been discussions about that. The other areas that are talk about immunosuppression, there's not anything dramatically new at this point. There was a drug that I and others have studied called everolimus, similar to sirolimus, published in the New England Journal of Medicine. You can actually see a framed copy of it over in, getting the New England Journal of Medicine. It's like you got in the Harvard, you get all these things in the mail. The important point of the study was that it showed that this new drug reduced rejection compared to the older comparator drug, azathioprine, but also reduced, this is even more important, reduced the likelihood of developing heart transplant rejection, heart transplant coronary artery disease. Coronary artery disease. And the important point of the study was that it showed that this new drug reduced rejection compared to the older comparator drug, azathioprine, but also reduced the likelihood of developing heart transplant rejection, heart transplant coronary artery disease. And one issue that came up, and this raised concerns for the FDA, was that people who took this drug and cyclosporin had higher creatinines. Kidney function was not normal, even if the cyclosporin levels were the same as people who weren't taking the drug. So the drug had been approved everywhere else in the world except the United States, Canada, and Britain, and has been used for about 7 years very successfully without any problems. And actually was approved in the United States last year for kidney transplant. But the FDA had asked us when we went to discuss this with them that, so the FDA in 2005 had turned down approval for heart transplant in the US and said we should do another trial, and this time compare everolimus to Cellcept, which has replaced azathioprine as the standard drug that we use with cyclosporin. So we did that trial. The trial was led from this institution. It's the largest trial ever done in heart transplant patients, over 700 patients. And 2 doses of everolimus were used. One of the doses, the high dose was stopped early because of higher mortality. It appears that if you use too much immunosuppression, people can get sick, which is something we really knew. The higher dose was not the dose that was going to be approved by the Food and Drug Administration anyway. It's not the dose that's approved anywhere. And it was actually the Food and Drug Administration's idea to use the higher dose. The lower dose showed significantly less of this transplant coronary disease than Cellcept. No difference in rejection, but less transplant coronary disease. There was a slight increase in abnormal kidney function, and the reason for that was that some people didn't pay attention to the protocol of the study. So you got to always pay attention to the protocol. The protocol of the study was that you use much less cyclosporin with this new drug, because this new drug prevents rejection more effectively, and you don't need as much cyclosporin. And if you did that, kidney function was normal. But there were places, a few centers in the study that were very reluctant to do that and adopt new ways. And so they maintained the cyclosporin at the higher level, and that the kidney function there was a little bit abnormal. So the study's been presented last year in San Diego at the ISHLT, and will be presented, the 2-year data will be presented at the ISHLT in Prague, and then at the American Transplant Congress in Boston. LIMUS. It's related to sirolimus aurata.
Thank you.
There is a big transplant clinical trial that is just starting underway, and that's funded by the National Institutes of Health. It's part of the clinical trials of transplantation. There are 11 of them. Most are in kidney and liver transplant, but this is the first randomized trial in heart transplant, and we're one of the 25 sites in the country involved in this. This trial is going to look to see if a medicine called rituximab can prevent transplant coronary disease. RITUXIMAB. So rituximab is a protein that blocks the B cells. The B cells are the cells that produce antibodies. And so although when we think about rejection, we think about the T cells, which invade the transplant. The B cells also are doing nefarious things. They produce antibodies that can damage the transplant arteries. And and also the heart. And it's thought that using this drug, rituximab, we might prevent this from happening. Now, rituximab is not an experimental drug. It's approved for use in lymphomas, which are from B-cell lymphoma. And it turns out we've also used it for many years in heart transplant patients, in patients who have the type of rejection that's caused by the antibody, so antibody-mediated rejection. We just used it successfully in one of our patients who was a few years out a few weeks ago. And it's generally well tolerated, so the study is just underway. The way the study will work is the new transplant patients will be randomly assigned to get the rituximab or a placebo. It'll be blinded in addition to all standard medicine. They get rituximab weekly for the first 2 weeks after transplant. So that's an interesting trial. It's just underway. We have a number of people who are enrolled in that. They're on the transplant list, and when they get transplanted, they will get the medications. Let's talk about ventricular assist devices now. So and that's all that I have about transplant at this point, and there's more at the ISHLT. I will let you know. Ventricular assist devices, the new device, or not so new device, the HeartMate 2, continues to, has totally replaced the older device and is being used with greater frequency. It's a complicated device, but it's associated with less complications. And so, as we know, it's used for two purposes. One is as a bridge to transplant. But the other is what's called destination therapy, where there are patients who are felt not to be good transplant candidates for a variety of reasons. They get the device and it's kept in. And that actually has taken off. So last year there were 1,200 devices put in. The year before there were 400. And I suspect the numbers will be even greater. I think we're putting in our 7th of the year today. So there are other people lined up waiting. And it really is dramatic how well people do with these devices. And the last person who got one was discharged in 10 days. Pretty good. Saw him yesterday, is an outpatient, looked quite good. I don't think this is going to eliminate transplant. Transplant is here to stay. But I think that patients who previously were maybe borderline candidates for transplant might now be considered for this device.
They're not battery operated?
They are battery operated. They're
Still
external batteries, so that's the same. The batteries are the same as the older device. But the older device was very big. It was clunky, couldn't be put in smaller people. It was associated with a risk of infection and a risk of just breaking down. And it was always very difficult for us. You never knew when the device would start to fail, and you'd have anywhere from 5 weeks to 5 minutes to change it. So those days are gone. In terms of newer devices or competing devices, there's a device called the, yes, Ken.
Do you expect the life expectancy to be the same, where it's not used as a bridge device, but as a permanent?
As destination. That's a good question. Nobody knows the answer. So if you look at the life expectancy in the literature for heart transplant, there is conditional and unconditional. Unconditional means everybody, and that's about 9 years. That's the average life expectancy. Conditional is probably closer to 10. Conditional eliminates all the people who died within the first year after transplant. But you have to remember, this information includes people, all transplants going back to 1967, when nobody knew how to take care of rejection. And even in the 1980s, in the 1990s, the outcomes were significantly worse than they are now. They're actually quite good now. So, what we tell people is that, if they do well after transplant, we expect that they could even conceivably have a normal lifespan nowadays. And I think that that's not, especially with some of the new medicines that we have, new ways to monitor the immune system, and new ways of using the older medications in a smarter way. I think that we're a lot better than we used to be. The new device, the longest that somebody has had the new device in is 7 years. I just saw one of our patients who is going on the end of her 5th year. She's our oldest here. And the devices have never failed. There have been other things that have happened. The drive lines that connect to the battery have cracked, the leads have cracked, the device can still get infected, or the device, people have to take blood thinners, the device can still develop clots. So those things have happened, and the device needs to be changed, and that's easier than with the older device, which was very, very difficult. But I don't know, if you ask me if somebody is a candidate for a transplant, they should get a transplant. And it's only if they're not a good candidate for a transplant and the risks are too high that they should be considered for this. So transplant is still the #1 option. It's like nothing better than the human heart. So let's talk about stem cells. I'm going to preempt you guys because every year Mr. Petronzio always asks me about stem cells. And, you know, I say it's the future and always will be, and I don't have much to say because there isn't much to say, but I actually have something to say today. Not a lot, but some. So there were two studies presented at the American Heart Association meeting in November. They've been published in the past 2 months in Lancet, which is a very prestigious journal, about stem cells. One's from Louisville, one's from Cedars-Sinai. And what they did in the Cedars-Sinai study and Louisville study was they got pieces of heart tissue and they purified stem cells from the heart tissue, and then they injected them into patients. These are patients who had had heart attacks. And what they showed was, big heart attacks, they showed that it actually made the heart function, and they injected it directly in the coronary arteries, so directly into the heart. And what they showed was that it actually improved heart function. And it's pretty crystal clear, and these people who did this are, you know, really good people. It's not like the guy at 60 Minutes who, you know, does his stem cell purification in Ecuador. So this is, it's a randomized study, so there was a control. The numbers were very small. So my view is that this is very encouraging, and there'll need to be bigger trials, and trials in different patients, including patients who are sicker. These still weren't the sickest of the sick. People with bigger heart attacks, people who have heart failure who don't have blockages in the arteries. Studies need to be done in them as well. We participated in a stem cell study 2 years ago. This was in people with not very big heart attacks. It wasn't using stem cells purified from the heart tissue. It was using something from the bone marrow called mesenchymal stem cells, which can be taken off the shelf and used in anybody. The purpose of the study was a safety study. It was safe. We don't know if it had any benefit. The company, by the way, that makes these mesenchymal stem cells has millions of doses stored away in case there's a nuclear accident or a terrorist attack or something like that. Chilling. But the study that we're going to be involved in is very interesting because in this study we're going to be obtaining bone marrow. This is going to be people with bigger heart attacks or more damaged hearts. And we're going to be obtaining bone marrow from the person, the actual patient, and putting that and purifying stem cells and giving it to the patients and see if it improves heart function. We probably will not have the answer to that for at least 2 years. But that'll be the biggest stem cell study. Again, you know, as you can see, every study has different stem cells, and it's not clear where we're going to end up, whether different ones will be used in different people. Whether it's going to be the mesenchymal that I talked about that you can get off the shelf, the ones from the heart where you have to do a heart biopsy, or the ones where you have to do bone marrow biopsy. And the ideal would be if we could get stem cells purified from blood, and there are stem cells, but it's hard to do at this point. And the other problem is that it's hard to get them to go to the right place or home into the right tissue. Bless you. Bless you. Hey, someone's catching a cold. And the problem is that if you inject a lot of these stem cells intravenously, you don't know if they're going to end up in the heart or not. They could end up anywhere. So it's still an evolving field, but I think there's a glimmer of hope.
How about make sure ethically right now, most of the stem cells are being taken from the individual to be replaced in the same person?
That's correct. So that avoids the issue of rejection because they're what we call autologous. They're from us. You know, the problem if you take stem cells that have somewhat matured and you use them in somebody else, they would likely get destroyed by the recipient's immune system. The mesenchymal are different because they don't have those proteins on the cells that serve as targets for the immune system. But the other stem cells do. And all of these studies that I've mentioned, none of them use embryonic stem cells, which, as you know, are on the one hand, are the stem cells that are what we call, you know, most truly pluripotent, which means that they can divide into everything and can develop the immune signature of the recipient, but which of course have to be obtained by destroying the frozen embryos. So that remains very controversial. But the ones I've talked about don't involve those types of stem cells. So I believe that is all I have to say.
I've been telling you that.
Stem cells, yes, you've been telling me that. And You know, I knew that eventually we'd live long enough that we would start to see this.
Oh, no. Did
Doctor,
you just say that right now you're feeling that our life expectancy is almost to be a normal?
I think so, yes. I think in general, unless there's some other medical issues, yes, that would be our goal.
Okay.
And I think that's easily
Because
achievable.
when I got transplanted, it wasn't.
That's correct. So there has been a real shift in the past 5 years. That's absolutely correct.
So therefore,
I mean, it doesn't change the fact that therefore you're going to be around for a long time. I know
that's
that.
what I'm saying.
And
Because otherwise my clock is ticking.
well, everybody's
I'm
clock is
almost-
ticking. Everybody's clock is ticking.
No.
Doctor,
By the way, I just want to remind everybody that Mr. Tronzio is a Giants fan and was overjoyed with their victory.
And again,
Yeah.
we're gonna take it every 4 years.
Every 4 years, you're going to take it. My son is in med school at Mount Sinai in New York, and he was one of the few people in his class not to go to the Giants parade. He went to histology, but he likes medical school, but the one class he hates is histology, but that was preferable to going to the Giants parade. His friend said, yeah, let's go to the Giants parade. He said, no, I'm not going to miss histology.
You know, Doctor, you were talking about that we have a normal life expectancy after transplant. This is true, from what I understand, in centers that are totally dedicated to post-transplant treatment. Not some of the smaller facilities that don't do as many transplants or have as much information about what goes on afterwards. And I think we're very fortunate, also to compliment you, to be at Hahnemann Hospital that has that regime in place all the time. And we're looked at very carefully, and it has worked out very well. And I think I can speak for all of us, we really appreciate the care.
Thank you. Again, it's a, as you know, it's a team effort. It involves the doctors, the nurses, not just the nurses here, the nurses upstairs, the people in the cath lab. It involves everything. But I think, there's a number of an important point that you make, which is that transplant should not be done by people who aren't dedicated. It should not be done just because it looks cool to put on on a billboard or an ad or something like that. It has to be, people have to be totally dedicated. The same is true for ventricular assist devices. You can transplant people who get into a lot of trouble because they aren't the right candidates. Same is true with ventricular assist devices. And there are centers around the country that, including some that are otherwise very highly regarded, that have outcomes that aren't necessarily all that good because of maybe not paying attention to all those things. So it is, people need to pay attention, they need to know what they're doing, and there needs to be total dedication. Thank you. Thank you.
Just a quick question for you. Just recently I was reading an article that I got from Jim Ellis in Illinois about transplant without drugs. And this particular is done by the University of Louisville. And it really speaks to the same things that you were talking about.
Yeah, so let me talk about that. And there is actually a Hahnemann connection, and there's a Temple connection to that too. So there was this idea that if you did bone marrow transplants, not complete transplants, but you gave donor-specific bone marrow to transplant recipients. In other words, the time you do the harvest of the heart, you also get some vertebra from the donor. And you purify bone marrow from vertebra, which are bones, and you give that around the time of the transplant, that you can reduce or eliminate a lot of the problems that happen, and perhaps eliminate the need for drugs. And that's called transplant tolerance. So we actually had a big NIH protocol at Temple about 15 years ago. We did that. Didn't really find any difference in terms of the group that was treated versus the group that wasn't. It was a blinded study. The solution that the stem cells were in smells like garlic. So people either got the garlic smelling solution with the stem cells or the garlic smelling solution without, so nobody knew. The patients also, for a few days afterward, their breath smelled like garlic also. It was a charming study. And if you touched the solution, it was absorbed in your skin and you would smell like garlic too. So, didn't show anything.
But if you're Italian,
Let me tell you, this is stronger garlic. This is like purified garlic.
This is what pastrami says.
So,
But there was another idea that perhaps the problem was that the bone marrow cells that we were giving didn't end up in the right place because they were just kind of wiped out by the immune system of the recipient. And so the way to do this was to weaken the recipient's immune system by giving drugs and giving radiation. And that perhaps then the bone marrow would take up residence. Bone marrow cells in the donor would take up residence in the recipient's bone marrow. And there was a little bit of evidence because there are a few patients out there who have bone marrow transplants and get complete bone marrow transplants and kidney transplants usually because they have certain kinds of diseases. And in those people, they never seem to reject their kidneys. So that was tried here, not a complete bone marrow transplant, but radiation and chemotherapy. And the results were mixed. It wasn't clear that it worked. The doctor who did that, I believe her name is, the doctor who did that moved out to Louisville, and I think they're continuing to try that. But I haven't heard any data at this point. And remember, we've been talking, this has been done 15 years over. So, could it happen? C. Fox.
Hey, how you doing?
well, actually, within this, I didn't read the total article, but apparently there's a tremendous amount of information on transplant without drugs. So I'll have to read it.
Well, let me talk about transplant without drugs outside of the heart.
Okay.
So, I mean, the problem also with the radiation was that some of these patients developed very, very low white blood cell counts that persisted continuously. So people are very reluctant, especially with successes with the drugs that we have now and smarter use of them, to perhaps do this. Now, there are circumstances where patients can get transplanted and don't need drugs. That's called tolerance. There's a significant proportion, not a majority, but maybe 10, 15% of liver transplant patients who don't need immunosuppression after a few years. And so the liver seems to work differently from hearts, kidneys, and lungs. And why is that? It's not entirely clear. But one thing that the liver does is it produces the proteins, the HLA proteins, that distinguish, I believe that was me. That distinguish donor from recipient, one person from the other. The HLA antigens, the proteins, are the targets for the immune system, the major targets. And it turns out that you put a transplanted liver into somebody, and it produces these HLA proteins, floods the system, and it appears in some patients to shut the immune response down after a few years. So there are liver patients who don't need immunosuppression. It's been looked at in kidney transplant patients too. So there's a population, very small population of kidney transplant patients who are non-compliant and decide to stop their medicines. The majority of them the vast majority end up on dialysis. But a small number actually develop tolerance. Their kidneys work fine and they're not on immunosuppression. Don't try this at home. Kidney recipients end up on dialysis. Heart patients who do this end up dead. The heart fails, people will die. There's a very small number of these people. They've been their immune system has been analyzed using molecular techniques. I think the most work was done by 3 different groups. One is a group at Stanford. One is a group called the Immune Tolerance Network in the United States, which is a number of different centers funded by the NIH. And there's a similar group to the ITN in Europe. And they've identified proteins and genes that play a role in this tolerance. In other words, people have kidneys that work totally normally and there are no immunosuppression. The problem with the tolerance is that it's not stable. So people can develop, for example, a viral infection, suddenly the immune system gets revved up and they can reject the kidney. So there's a lot more that needs to be done. You know, tolerance is the holy grail of transplant, but we're not there yet at all, especially in heart transplant.
Okay, thank you.
Yes?
Over the years, approximately 2,000 heart transplants are done every year.
Yeah.
It's never gone up, never gone down. Anything can be
Actually,
done
it has
to
gone
change?
down. It has gone down. So in the 1990s, late 90s, it was probably in the high 2000s. And it's gone down. In 1997 in Philadelphia, there were 160 heart transplants done between 3 centers. Temple did 85 then. The number now is probably as low as about half. So some of the news, a lot of the news is good. There are fewer people on the list because there are a lot of things that can be done to prevent the need for transplant, at least initially. Medications, special kind of pacemakers, things like that. The other reason is that the number of donors has declined. Some of that is good news as well. There's less gun violence. And when people succumb or are affected by gun violence, there's a lot more that can be done. The other thing that would cause brain death would be strokes. Neurologists are much better now at managing big strokes. So a lot of the things that would lead to brain death can be managed or prevented. There still are people who have brain death, and I think the problem is still that there are people who are potential donors who just for one reason or another never donate. Last May I was in Cordoba in Spain, southern Spain. It's in an area called Andalusia. So Andalusia has the highest organ donation rate in the world. And the two things they do, one is that they really put donors on a pedestal. They have a big monument to donors. They have special sessions where people write poetry about their loved ones who donated. I mean, donors are really put on a pedestal. But the other thing they do, which is at least as important, is they have presumed consent, which means unless you told somebody during your life or put it, on your driver's license that you didn't want to be an organ donor, you're an organ donor. And that's the other thing. I don't think that would ever happen in the United States. The other place that does that is Austria. So Austria is the other place that has the highest rate of organ donation. And it's the same reason. And in Austria, it actually goes back to, this is what I thought was kind of interesting, it goes back to the Austro-Hungarian Empire. Now, they weren't doing organ transplants back then. But they had a law where everybody who died had to give their body to science for autopsies. Kind of foolish. Unless you said, no, I don't want to give my body to be an autopsy. And that's been extended now to people who have brain death and the fact that the organs can be used. So that's the one way that you would increase the number of organs. I mean, we've had, over the years, we had Michael Jordan making pitches, we had Michael Jordan's face on buses in Philly, and it's been very difficult.
Yet
So
I
good
understand.
news, not so good news.
I understand, despite presumed consent, Spain still does ask the family for permission. They publicly say that.
They do, that's correct. But they can go ahead, the families understand that the people can go ahead and do this. But, that plays into the first thing I said, which is that donors are treated with, tremendous, donor families are treated with tremendous respect. They are really honored. I mean, I saw an exhibit, no problem. He's a man on a mission. I saw an exhibit of artwork that donor families and donors before they died had painted. I mean, it was really amazing. It had tremendous attendance. I mean, everybody in the hospital, and a lot of people from the community were there. The state minister of health for Andalusia was there. I mean, it was a big deal.
How big of a population is that place?
I don't know how big Andalusia is. It's one of the bigger states. I would guess maybe 5 million. Cordoba, it's where Sevilla is located there. Cordoba is, about 1,000 years ago had 1 million people. It now has about 250,000. But it's probably near about 5 million overall. But it's the whole country.
Doctor, just in relation to that, reduction in transplant have we made any progress in preventative measures in order that
So
these things don't?
I think that's the case, and that's why I said that, one thing is that there are a lot of, there are a lot of therapies that we could use that prevent people from needing transplant. So the people who come to the point where they need transplant now really need it. I mean, this is my 25th year of doing this, and in the mid-1980s, we didn't have ACE inhibitors. We didn't use them in heart failure. We didn't use beta blockers. In fact, if you use beta blockers, they'd probably arrest you. We didn't have resynchronization therapy. We didn't have sophisticated defibrillators. And then of course we didn't have prevention with things like statins. So I think all of those things have contributed to fewer people needing transplants. The people who need transplants now are people who are out of options. They're completely out of options. Because when we get a transplant evaluation, we make sure that we try to exhaust all other options. And then most people refer to us for transplants with medical therapy, sometimes surgery, biventricular pacemakers, things like that. We are able to prevent them from needing transplants. So that has actually progressed significantly. But it's the people who really need them who still have to wait.
Doing pretty good. You guys are doing a good job.
Thank you. Thanks.
Is there any waiting in the hospitals now, or is everything on the outside?
There's one guy, most people are outside now. But the people who are sick still wait in the hospital. There's one gentleman who's a status 1A here, was listed at the end of the week last week, who's waiting and will likely wait. He's too unstable. People who are too unstable end up still staying in the hospital. What Ken is saying is that it used to be that people would wait in the hospital. I think a lot of you knew that. When we were at Temple, we were reluctant to send people home because we'd be sending people home with on milrinone, which at the time we didn't know what would happen, even with defibrillators. So we wanted to see what would happen to other people's patients. So when they would send us home, if they did fine, then we would send our patients home. And that ended up working. Transplant patients just had a medical problem, and that was one of the surgeons. I think that just points out to what Mr. Golden was saying, which is that it's good to have an institution where everybody's on the same page, everybody knows what to expect from transplant patients, and there's free communication, free collaboration, and that's been true here. So that's all I have to say. Yes? Jim?
What percent of post-heart transplant patients develop diabetes, and what can we do to reduce that number?
Yeah, I think that it's the numbers are all over the place, but it's probably about 25 to 30%, ironically, of new onset diabetes. Ironically, it's a little bit more common people get programmed. So one thing that we will do is we'll switch them to cyclosporin. A lot of patients develop a metabolic syndrome after transplant, and if they can lose weight, that's very helpful. One thing that we do here is that we try to get people off steroids very quickly. And there are some patients who we can't because of concerns about rejection, but the majority of people are off of steroids within 6 to 12 months. Steroids is associated with metabolic syndrome and developing diabetes. And it's something that I've been very interested in going back to the mid-90s. At Temple, we were among the first to do that. I remember one of my cardiology fellows got up to 1995 to present our data, which were quite good, about this at the Eisen, our transplant meetings, and some people thought that what we were doing was entirely unethical. So the data was very good and it continued to be good. And a lot of places do this, but if you look at the registry, the ISHLT registry, the percentage of people who are on steroids at 5 years is still a majority. So I think one thing we can do is get people off of steroids, unless there's a really compelling reason for them to stay on steroids. And that's one thing that we've been doing. And then trying to get people to lose weight, and if they're on Prograf, then perhaps switch them to cyclosporin.
But if they went to Prograf to get off cyclosporin because of the effect on the kidneys, what would you do then?
Well, the Prograf and cyclosporin have the same effect on the kidneys. There's no difference. Prograf has some advantages. It may be a more powerful immunosuppressive agent, so maybe a little bit more powerful in preventing rejection. People who have gum growth, Prograf doesn't do that. So what we find, instead of sending people to surgeries, we just switch them to Prograf, and very often the gum growth disappears. And then Prograf is less likely to cause hypertension. Cyclosporin, over 90% of patients develop hypertension. Prograf, it's about 50 to 60%.
A couple of years ago in one of these updates, you talked about what you were learning in terms of handling rejection, and you certainly were of the opinion that we've been over-medicating all these years.
Yep.
Has that changed in your mind at all? Has that progressed any further? What do you think today?
I think that we have been over-medicating, myself included. I think one thing we learned from the original study that ultimately led to the development of the ALAMAP, the cargo study, is that over 60% of the things that pathologists, including very experienced pathologists, call rejection that needs to be treated, 3A, or now we call it 2R, is actually not rejection. It's a much lower rate and wouldn't need to be treated. And interestingly enough, there was a second study called the Cargo 2 study, which was mainly in Europe. There were a few North American sites, but overwhelmingly in Europe, and they found the exact same thing. So, it's always good in science if somebody reproduces your results. So I think that's the case. And, we're more careful at looking at biopsies, and also I think the ALAMAP has helped us to eliminate biopsies in stable patients, so we don't run into this problem of overcalling biopsies. And the other thing is that we use too much cyclosporin and Prograf over the years, and when people had elevated creatinines, we assumed that it was the cost of doing business, and now we try to reduce the levels of those drugs as needed, and it may not be possible to do in everybody in terms of lowering the creatinine, or it may not be possible to lower the drug levels. But we try to do it, and most people were successful at this point. So we try not to tolerate a creatinine above 2 in sort of the average patient. There are patients with extenuating circumstances where there's no way to avoid it.
What makes creatinine levels fluctuate?
How much fluid is in your body? If you get dehydrated, it can go up. Cyclosporin levels, sometimes Prograf levels, sometimes we see people whose levels are high and the creatinine's high as well.
You also indicated that not everybody has adopted ALAMAP, or it hasn't been as widespread as we might have expected. Why is that? Resistant to change or not effective?
There's the non-controversial answer and the more controversial answer. So the non-controversial answer, which is true, is that there are people who are conservative and are used to doing biopsies. They don't want to change anything. And the controversial answer, which is true in some places, is that biopsies are a source of revenue. And there's no getting around the fact that you do a lot of biopsies, especially outpatient biopsies, you make money.
Unbelievable, huh?
That's business, hey.
No.
Don't be surprised. That's business.
As Michael Corleone
drug
said,
side.
nothing personal, or no, actually it was Don Vito Corleone said, nothing personal, business is business. It's just, but that is the case. Now, I'm not going to say everybody who doesn't use ALAMAP is guilty of that. But there are people who have, quite flatly said, look, this is a big source of revenue. And where it becomes an issue is that there are some medical institutions that use a way of determining the value of an individual by something called the RVUs. And so that's based on how many procedures you do. So if you're sending out a blood test, you're not doing a procedure. If you're doing a biopsy, you're doing a procedure.
It's known as the gold standard.
Yeah. The gold
I have
standard.
a
That's right.
I have a question
Yes.
for you. Has there been any studies indicating that if you got us off the steroids faster, for an example, on closer to the 6 months, we will have less dependent on our caregiver than if we stayed on the steroids?
Yeah, I don't think
longer?
it's a very good question. I don't think anybody's looked at that.
Okay.
I don't think anybody has. That's a very, very good issue, a very good thing to think about.
And the reason if I may, the reason I asked that question, because, some of us, naturally, are independent anyway, but we realized that when we were on the steroids, we were not independent, we were very dependent. And we wanted to get off, we wanted to be able to do our own thing, and as we got off of those drugs or those steroids, we were more able to be more independent.
I don't think anyone's looked at that, but that's an interesting consideration. It would not surprise me. But
maybe I should do that research.
You should.
No, I'm only kidding. Just kidding.
Don't.
Open mouth it, certain foot, not me.
No.
Steroids do
It's crossed my mind.
affect individuals differently all the time.
They do. So any drug affects people differently. So steroids do too. But you know, the things they do, they cause diabetes, hypertension, they can cause the bones to be weak, they can cause the skin to stretch, they can cause cataracts, put you at risk of infection,
Mental
increased
issues.
infection, give you acne.
Also,
Actually, the
men-
acne is the easiest thing to treat. That we, Red and A does wonders with that.
well, also mental issues as well.
Yes, so they can make people agitated, they do all sorts of things. Hyper.
Psychological.
It was not, you know,
Is that it?
there was there was something called the steroid honeymoon when I first doing this, where, you know, people would, you know, you'd walk in after the transplant, you know, and people were hypomanic, they were getting lots of steroids, you know. Doctor thanked, you know, you and God and all these things. It was just, and then, you know, they would crash after a few weeks. Come down with
what have you
steroids.
done for me, doctor?
And, you know, I remember one surgeon coming to me after just seeing a patient who was otherwise doing really well, but was now depressed. A few weeks from transplant, he said, increase the steroids. He was joking.
The plane crashed.
So we don't use as much steroids, we don't see as much of the high that we used to see. But, yeah, it can affect the mind too.
Oh, yeah.
Doctor, can you talk about the generic versus brand, specifically
Yeah,
Provac?
yeah. So, when the generic cyclosporin first came out, there were a few different ones. And there was only one that, and we can monitor them very carefully because we just check the drug levels. So there was only one that was really very good. The others, we get all sorts of crazy drug levels, usually too low. So we just used the one that we felt was reliable. And with Prograf, I think it's the same, that we just check the drug levels, and if they're okay, then the generic is fine. And that's a difference that some other drugs don't have. I mean, there's some drugs where you can't very easily measure the effect by using drug levels. So you never really know if the generic is as good as the original. In some circumstances, some people feel certain brand forms of warfarin, Coumadin, are better than generic. Also, furosemide or Lasix the same.
Doctor, on generic medicines, does it matter who the manufacturer is?
Well, that's what I'm saying is that, you know, we monitor levels, and in the past with cyclosporin, there were a few that were not good. And we knew that immediately because the levels we got were crazy. It was the insurance companies that said, you've got to use this. And there was one in particular that was very good. It was totally reliable, so we made sure we used that one.
How did you make sure you were using a particular brand of a generic?
We would
Can you do that?
specify that we wanted a generic and that we wanted this particular generic.
I was of the opinion, and not fact or case, that the pharmaceutical companies, or not pharmaceutical companies, the drug companies
Pharmacies, yeah. We would call
were
the
buying whatever
We would call the
they get deals
pharmacies.
on.
We would call the pharmacies and make sure. There were some pharmacies that didn't have this
Right.
generic, and so we made, and I think all the generics now for cyclosporin are fine.
Okay.
This was, 13, 14 years ago.
I was curious, I've heard that in some instances that, say with Prograf, which is, that some people still take that, and if they notice any great variation in the levels, the doctors will, and can talk to the insurance company and say, look.
Yeah,
let's take
sometimes.
that.
I mean, again,
How
there
does-
may be some people for whom the generics are not good, and they can, if we document it, we can talk to the insurance companies. That happens sometimes.
Okay.
Yep. And again, with transplant medicines, we know with Prograf and cyclosporin, we know because we routinely check levels.
Well, you find out pretty quickly anyway, because after 2 weeks of getting onto the generics, you have to come in for testing.
Well, you know the levels. That's exactly
Yeah.
right. People don't even need to come in. They can get levels checked locally.
Right.
Yep.
When I say get it checked out, I mean actually having to come
Yeah.
here.
What are the current protocols in terms of age and being eligible for transplant, especially in terms of age and second transplants?
So age in first transplants, there's no set cutoff, and it depends upon biological age of the person. So we've transplanted people into their early 70s, and if they're biologically young, that's fine. And similarly, there are people who may not be great transplant candidates for a variety of medical reasons, who biologically are older than their stated age, but are under 70 or 65.
How about donors' ages?
I'll get to that in a second. Second transplants, we're a little bit more restrictive. There's no set cutoff, but Again, it has to be the same thing where there's no, biologically they're younger than otherwise. Donors, in general, we try to stay under 40 to 50. Sometimes we will take older hearts if they're good hearts, above 50. And we take them sometimes if they're good. But we don't, for example, we don't put a 50-year-old heart in a 20-year-old. So we try to match the age. 50-year-old heart in a 70-year-old or 65-year-old, it's perfectly fine if the heart's good. And we know a lot about the donor hearts at this point, all sorts of things, including catheterizations done on the donor.
Okay, are there any other questions? Well,
All right.
sir, we do appreciate it.
Well, thank you very much.
As always.
Thank you very much.
Don't forget to have some lunch.
I will have,
The price is right for you.
Cranberry and raspberry.
Yeah, all right.
grab one of those.
That'll do it to you.
Thanks again, sir. We do appreciate it.
You have a question? Yes, I knew you'd have a question.
No.
What about stem cells? I told you about stem cells.
Thank you, Doug.
How
By the way,
the
this is-
idea.
You probably have seen this already. This is what I saw. Yeah.
Yeah, University of Louisville. That's what
Yeah. Yeah, Jim sent me some information. I decided.
Now, there is, one other thing, and again, this is, at this point, this is science fiction, but there is discussion about, science, yes, today's science fiction is tomorrow's science fact. There is discussion about trying to use stem cells from patients to build new hearts. And the idea that you build a scaffolding and you put the cells in. And they've actually done that with bladders, and they've done that with trachea, the windpipe. So those have been done. Hearts are much more difficult. There are people working on that, but I think we're several years away. I mean, if you think about that, that might eliminate transplant and VADs, or transplants from other people in VADs entirely. If somebody can just throw their own.
Not in our lifetime.
Probably not.
Speak for yourself, Ken.
Speak for yourself.
Those little guys who are here, probably in their lifetime. All right, thank you.
Thank you, sir.
Thank
Appreciate
you.
it.
Thanks,
Take care.
Doctor.